Good evening, everyone, and you've made it through. Last session of the day, and it'll be hopefully an interesting one and lively one. So I am Alice Park, Senior Health Correspondent at Time, and it's my pleasure really to be moderating this discussion this evening with these women on stage. And I'm going to introduce them first because I think it'll tell us a lot about where we're going to go with tonight's session. On my immediate left is Dr. Martha Galati, a cardiologist at Cedars-Sinai Smith Heart Institute. And next to her is Dr. Diana Thiara of the UCSF Weight Management Program. And next to her is Dr. Nora Volkov of the National Institute on Drug Abuse. And you may be wondering what an expert on drug abuse, a cardiologist, and an obesity expert, obesity physician have in common? And the answer is GLP-1s. So I think the breadth of the expertise we see on stage here is an indication of really how powerful the GLP-1 weight loss medications are, and it shows you the breadth of their potential as well. So tonight we're going to be discussing really where we can go with this drug class beyond weight loss and beyond treating obesity. It's where a lot of the most exciting research stands today. So I wanted to start with you, Nora, and you've been working on drug addiction for many years now and understand a lot of the reward circuits in the brain. So tell us what a drug that works in the gut or that works on obesity and our desire to eat, what that has to do with the brain and with addiction, which is what you're studying these drugs for at this moment.
Yeah, no, this is correct. And in fact, I have been working all my life professionally on addiction, but I also in parallel have been working with understanding the changes in the brain in obesity. Because when you have compulsive patterns of eating behavior, and you actually, many of which are driven by the reinforcing, rewarding effects of food, you come to realize, and I've been involved with doing neuroimaging studies to see what are the changes in the brain of addicted people and how do they compare with the changes in the brain of morbidly obese people. And what we have seen are common elements that are occurring in both of them. And as a result of that, we had put forward the concept that in the case of addiction, there was a dimensional component of addictiveness, and that there are certain foods that can generate these compulsive patterns much more than others. And it is important because it drives a very significant contribution for the obesity that we have. Now, this, if you look at it physiologically and evolutionary, had to be expected because what drugs do is they make you seek them because they are rewarding, and they activate the reward system, and this reward system was developed evolutionary to promote behaviors that are necessary for our survival. So the way that biology solved the problem about how you incentivize each one of us to do the behaviors to get the food so we survive is by making it rewarding. So these reward systems are evolutionary extremely old. And food is one of the main circuits that drives it. So drugs hijack that system. So that's why I say it's not surprising, since the neurocircuitry that is the motivational drive that has these rewarding things that are rewarding, reinforce in our behavior and want us do more. And they also, interestingly, condition us. So when you get exposed to something that is very rewarding, your brain automatically creates a memory that's very, very long-lasting and immediate, what's called conditioning, that Pavlov first described with his dogs. That is driven by this reward system, and it happens with drugs, and it happens with foods. It just happens that food are very powerful rewards and reinforcers. So now that we are seeing, and we have been noting this from studies in laboratory animals, that when you give these GLP drugs, and this is more than a decade ago, we've been funding this research, the animals take much less drugs, and in animal models of addictions, they don't relapse. And now that these medications have been used for diabetes first, close to, I think, more 20 years, that you said, so 20 years. There's a lot, and we have electronic health records. We can go back and see that people that say, for example, were smoking cigarettes or have an alcohol use disorder, but also had diabetes and obesity and were receiving these medications, when compared with other patients, similar patients that were receiving other anti-obesity or anti-diabetic medications, they have much less problems with drugs. So the data out there, and patients will tell you, you know, it's interesting, they put me on these medications and I don't feel that desire to drink alcohol. So the data, but we need to actually, what we're doing right now is do the randomized clinical trials to determine if they're valuable. So that's how it happened.
Okay. I want to come back to that and the idea of whether, you know, at some point we can get to the stage where we are looking at using these drugs or versions of these drugs just as an addiction treatment, you know, versus does the person have to have overweight or obesity? So I'm going to come back to that. But Martha, I wanted to come to you and tell you that, so right now, these medications have an indication for their ability to not only reduce obesity, but also reduce the risk of heart disease by 20%, which is huge. And I have to say, I was at the American Heart Association conference when the study that revealed this result was announced, and it was a, you know, standing room only, probably about like 20,000. Most of the attendees were in the room, and I have never been at a scientific conference where they got a standing ovation. And it was twice during that presentation. So, and I was talking to a lot of heart experts in the room, and they told me that they've been waiting a very, very long time for something that really could help them talk to their patients and treat their patients with obesity, because they've had something to give them for cholesterol, for hypertension, for diabetes, and for obesity, it was diet and exercise, which, you know, we know studies have shown can only go so far in reducing weight. So tell me a little bit about the impact that these drugs are having on the heart disease community, and, you know, as a physician treating people with heart disease, what are you hearing from your colleagues about what role these medications are playing in their practices?
Yeah, this is a game changer for our cardiology community in terms of having something that treats the problem and reduces cardiovascular risk. For years, we've only had what didn't really work. We tell people to eat less, move more. That was sort of the tagline. And we all know that that was, you know, as if somebody who had excess weight had not tried all those things and cycled, you know, between their weights. And especially for those people with cardiovascular disease, we knew that they wanted to lose weight. They wanted to do the right things. They were more likely to quit smoking than to lose weight. And quitting smoking is one of the hardest things you can do. And so we really couldn't tackle this problem effectively, even with the medications that were available for weight loss. Although the weight loss was small, a lot of them caused high blood pressure. So we really didn't feel equipped. And what happened in the cardiology community is we stopped talking about weight. We actually would ignore literally the elephant in the room. We wouldn't talk about it because we didn't have a lot to offer. And that really led to just sort of, well, we'll manage all the risk factors that we know, and hopefully somebody else will address their weight, but it probably won't be me as my cardiology community. So having these drugs and being able to, first of all, address something that is a disease, but also is a risk factor for cardiovascular disease, really changed the way of thinking. It changed cardiology almost overnight. Once these drugs got approval, we wanted to use these drugs. Now, there's, of course, some barriers to using those drugs, but for the patients that have gotten them, what has been remarkable is watching the reduction in cardiovascular events, the reduction particularly in heart failure. Heart failure, we really, you know, that's one of the most common reasons people go back to the hospital, in and out, in and out. And suddenly, we're able to reduce that. That has changed overnight how we're practicing cardiology. Additionally, we'll see other risk factors for cardiovascular disease go down. So meaning the cholesterol gets better controlled, the blood pressure gets better controlled, the diabetes or even insulin resistance or prediabetes tends to get better. And so all of these things changing at the same time, and then additionally, as you already said, for patients who did maybe like alcohol before, and we might have told them that would be a great way to lower your blood pressures, just cut it out, or for heart failure, we don't think you should drink. Suddenly they're telling me I have no appetite for alcohol, and that's also changed how we can really take care of patients with heart disease.
Yeah. And Diane, of course, the biggest impact has been, in patients with obesity. Can you tell us a little bit about some of the ways that now obesity specialists like yourself are looking at these drugs and getting a better sense of how to use them, in which patients you should be using them, and whether you're starting to see, I guess, a coalescing around some criteria for determining, who should be on them, how long. I know they're relatively new to the field, and they've really just they're suddenly everywhere. But are we seeing any consensus on how these drugs could best be used to benefit the most patients?
Well, the first GLP that was FDA approved for use in obesity was Saxenda, and that came out in 2013. So those of us in this space are not unfamiliar. It was more that it became a more effective option with Wegovy, Ozempic, and it disseminated to the public more effectively.
And the weight loss reduction was more, right, with these versions?
More weight loss and maintenance of the weight loss. That's why the older classes of medications didn't have that reduction in cardiac morbidity, mortality, because people would gain weight back after a couple years. In terms of our community deciding on who to treat, the idea of obesity being BMI and that's it is sort of passé. It's a very common disease, and a screening tool for such a prevalent disease has to be simple. But we also need to look at the individual person and not necessarily assume someone's health status based on the way they look. Someone who might look average weight could have a lot of weight-related comorbidities because of where their adiposity lies or their genetics. And conversely, someone who might look a little bigger may have a completely metabolically healthy profile. So we try and have a very comprehensive approach. We also have more medication options now, and we try to have that precision-based medicine. We know there are certain hyper-responders. They tend to be women under the age of 50. And so I would love to have this academic, algorithmic approach that's really fine-tuned and finessed, but we're very, very dictated by what insurance will cover. And insurance, in my opinion, does express bias around how they treat and think about obesity. So it has to be followed to the T on how the study was designed. And that's not the case for something like hypertension or diabetes, where those studies also had lifestyle change components. But when it comes to the obesity treatment, it has to have certain BMI requirements and certain levels of engagement that the patient has had to have with that lifestyle change before the drugs will get covered.
So one of the, I think, exciting things about these medications, this class of medications, is that we're learning more and more every day about, benefits, health benefits that they can produce. We're seeing changes in the heart, kidney, liver, in the brain for addiction, for Alzheimer's disease. I know the makers are studying them for Alzheimer's disease. And with obesity, a lot of those metabolic conditions that you mentioned. Nora, could you address, these drugs belong to a class of compounds called incretins. Can you tell us a little bit about them, and are they the wonder target, for drugs, and they seem to be, they seem to have receptors in many different organ systems in the body. So how long is that list of potential, indications that we could see for these drugs over the next few years?
Yeah, no, and also, in a way, too, I'm going to add, and what does it tell us, really, right? That we have one molecule, an incretin, that basically what it does, it makes your body much more efficient in utilizing glucose, which is necessary for energy. So when you become diabetic, you cannot produce insulin, which is necessary for the cells to actually you don't respond to insulin, which is necessary for the cells to be able to take advantage of glucose. And that is what triggers diabetes with all of the metabolic syndromes associated with it, which include a very significant inflammation. And so what we know from these drugs is, number one, that they improve energetics and glucose utilization, and that's sort of why they started being used for diabetes, but that they also significantly reduce weight, because people feel satiated faster, and that attraction that they had for unhealthy foods, the obesogenic foods, apparently is degraded. And as a result of that, is not that they not are hungry, but they decrease the amount of food that they are taking. And that then decreases the weight, and that then decreases the inflammation. So what it's asking in my brain, because you say it is Alzheimer's, there's evidence from electronic health records that they may be beneficial in reducing the incidence and in reducing the severity of the dementia, which may relate to its vascular effects. There's also studies going on for neurodegenerative diseases apart from Alzheimer's, like Parkinson's disease. In the psychiatric world, the companies are interested in evaluating the potential of these treatments for conditions like depression and schizophrenia. And why? Because there is a recognition that inflammatory and neuroinflammatory processes are contributing to these psychiatric diseases. So there are ongoing randomized clinical trials to study the effects of these medications in these other psychiatric diseases. We study the ones in addiction, but again, the work is ongoing, and I was speaking with one of the big companies that is involved with this in this development, and they're also evaluating its potential utility for chronic pain conditions, which also have an inflammatory process. So what it's telling me is how consequential inflammation may be to the health of our body. So we spoke about inflammation, and we have the autoimmune diseases, your gastrointestinal tract, your skin, your heart, but it's sort of, in a way, it's permeating everything. That's one. And I also think, and this has been much less studied, but it's something that haunts my brain. They make energetics more efficient. And we know that in the brain the neurons are very sensitive to lack of glucose and oxygen. So if we should be evaluating what are the consequences of improving energetics also in the brain. That is not something that I have found research on, but I'm just speculating at this point that this could be one of the mechanisms why we're seeing those widespread effects. But before I shut up, I do think that I always said to myself, Nora, don't get so excited about these medications because they look very good. We need the randomized clinical trials, and people are already seeking out physicians that will prescribe them for addiction or for other conditions. And I do think it has happened in the past. We say we have the panacea, let's wait for the data, but it does look very interesting.
So, but that data will come, but at this point, I want you to make some predictions based on, the work and the data that you have seen. Do you think we will get to a point where we will have one of these types of medications, maybe not the exact ones that we have today, but if we have this group of compounds, that address the inflammatory factors and other parts of the body, in different ways? Do you predict we'll get to the point where we might have some of these medications that will be specific to addiction, that people would be able to take without having an indication of overweight or obesity?
That's what we're aiming for, and that's what we're doing, the randomized clinical trials. And again, it's working at the end of the day also with the pharmaceutical industry, because they are the one that's going to take that product and bring it into the market. We, as a research agency, can basically de-risk and help them go through it. There is interest, and there is interest actually from big pharma to bring some of the new compounds for addiction. Now, and it is, we were discussing before, because one of the issues that ultimately, as we're doing these clinical trials, is people that, for example, have cocaine addiction or methamphetamine addiction. Some of them are very emaciated because stimulant drugs decrease your appetite. And so the question is, could there be negative consequences to them? So one could conceive of modifications of that molecule that may be less effective on decreasing weight, and yet be able to modulate the intense desires for drugs. It's a theoretical question. I do not know, because the neurocircuitry is the same one that drives food intake. So we will see.
But that research, all of that exploration will likely come from, experts like yourself, right? That are doing the basic fundamental work on understanding this class of molecules better and all of their effects in the body, from the inflammatory effects to the brain to different organ systems.
Yes, I mean, I think that the basic fundamental research will help us advance a lot because, for example, one of the questions, and I think you were hinting about it, we are targeting these drugs for the GLP receptors, but it's possible that they may have other targets. So we need to study them. But it's also clinicians, and these are recognition. I mean, so we did have the studies in rodents, but it was until the clinicians also starting to tell us about what their patients were telling us. So we all have a role to play back and forth. So discovery is not done in isolation in the lab, and basic science is fundamental. But if you don't do that bridge with the clinical world, with the policymakers, and with industry, then all of these discoveries don't have the impact that they can have.
Right. And Martha, I want to ask you a similar question about in the heart disease community. Are you seeing cardiologists getting comfortable with being able to prescribe these medications? Are they referring their patients who they think could benefit from them to an internist or obesity management program? And in your view, should heart doctors be able to prescribe these, and should they be prescribing them more?
Well, I think our cardiology community is very familiar with them already, and I'll give you, there's some exceptions to the rule, but I will say that, all these drugs, as we already mentioned, were developed for diabetes, and so we already had a lot of patients on them. And maybe people in this audience may or may not know, because of prior mishaps with diabetes medications, it's now a requirement for any medication developed that can control diabetes to prove that it's not harmful to the heart. And what was interesting about this class of medications is we found not only was it not harmful to the heart, but actually beneficial. And that was part of the studies early on. And then we started asking these questions, well, what about people who don't have diabetes, and can we use them in them? And that led to the burgeoning of studies in cardiovascular disease. So we've looked at people with atherosclerosis, we've looked at people with heart failure, and specifically heart failure with preserved ejection fraction has been of great interest specifically for this medication. We have ongoing trials looking at atrial fibrillation. We do not know the answer about that, but those should be coming. So I think my heart failure community of physicians are definitely comfortable with these drugs because so many of their patients already had diabetes, and because of the use of these in that class of patients.
Regardless of whether they're overweight or obese, just looking at as a heart treatment.
And I think that they're definitely a group. They've never been shy away from new medications because their whole arena is new medications lately, which has been very exciting for anyone with heart failure. We can do so much better by them. So I think that group is fine. I think preventive cardiologists like myself, we're always on what are our new medications, what can we use, what can we do to help people. So I think my preventive cardiology community is definitely on board with them and not having any other issues. I would say everyone else, it has been a little hit or miss. I get a lot of referrals from my electrophysiologists, for example, not familiar with how to do it, but just want it in my hand. It's not a procedure, so they're not that interested. But they do want to get these patients on those medications, particularly those with obesity. They know it affects the disease process that they care for. So I think that what's happened, I mean, if endocrinologists or obesity specialists, there's just not enough of them. And I think the reality is that we need more both primary care physicians familiar with it, as well as cardiologists, to really cover the patient population that we're talking about that suffers from obesity or overweight with cardiometabolic disorders.
And in preventive cardiology, is there a hierarchy where you would look perhaps and be more likely to prescribe these medications for someone to prevent a second event You know, a recurrent event who's already had a history of heart disease, I think that's one of the criteria now for the indications, right? But
Yes.
could we eventually move to a point where someone with a lot of risk factors to prevent a first heart event would be eligible for that?
And we are doing both of those. We are doing primary prevention, meaning somebody without heart disease, but a lot of risk factors. When we see that organs like the kidneys have already been affected, the liver have already been affected, they have lots of cardiovascular risk factors, we're already using them. For those with heart disease, it's actually easier to get approval these days if you have cardiovascular disease. And so we are using them in that population as well. People with heart failure as well, we are using that because heart failure, one of the biggest costs to society is heart failure hospitalizations, and we're finding that we can keep people out of the hospital with this and other medications. So I think there's lots of opportunity to be on the entire spectrum. The biggest challenge, of course, right now is access and whose insurance will cover it. I just was checking my messages from today, and we got another message of a patient who we had prescribed it to for all the right indications, but didn't have cardiovascular disease yet. But they said, well, the BMI isn't above 40, so we won't cover it. That's crazy if we're going to wait for BMIs above 40. We just wrote a statement. It came out on Friday. And that statement through the American College of Cardiology, even when we went as far as the co-chair, so we went as far to say that diet and exercise has never worked. You don't have to wait for it. You should, of course, use it, but also use the medications first line. So we're hoping someone will listen to us just by our recent statement.
Okay. Diana, I wonder if you can talk a little bit about some of the side effects that we've seen. Obviously, the GI side effects we hear a lot about, but there's also reports of rare eye conditions, blindness, vision loss, things like that. Can you talk about that and the fact that what we know about the different effects that these drugs could have on the body, right, on different systems, and your opinion about whether they should be prescribed by those who have special training, more knowledge about them, you know, your view as an obesity specialist, who is best able to prescribe and what additional education or training might be necessary for those who maybe don't have a specialty in obesity care?
The side effects totally make sense when you understand where all these receptors are in the body. And so the GI side effects are common because food sits in your stomach longer. There's increased pyloric tone. And we mitigate a lot of those GI side effects through nutrition counseling. And one of our policies and protocols is patients need to come see us before they dose up titrate. The same for hypertension, the same for diabetes. You don't just send a message to your provider and say, put me on the next dose. You check in, make sure things are going safely and health promoting before you increase. So we try and mitigate GI side effects through lifestyle, nutrition, fiber supplements, things like that. There are rare but serious side effects, things like pancreatitis and cholecystitis, which are quite rare. And then this eye complication has been seen in patients who have diabetes. So perhaps people who have increased risk for retinopathy or other eye-related diseases because of that diabetes state. It has not been seen in the patients who have obesity alone. So that is also something that we're not as concerned about in the patient population who has obesity or other metabolic risk factors that aren't diabetes. In terms of your second question, there just aren't enough obesity medicine specialists, and there are even fewer obesity medicine specialists who are trained through a fellowship program. So it's unrealistic to expect obesity medicine physicians to be the ones caring for all of our patients with obesity. Now, perhaps we can do a better job sending patients to tertiary care center who have obesity and need a transplant or who have super complicated cardiometabolic disease, but someone with class 1 obesity or class 2 obesity and a few disease states that are early could very well be managed by a general internist or primary care doctor. What I say to my grumbling residents when they talk about GLPs is that the issue is it's one of the first medications in my memory that was directly sent to the PCP instead of the subspecialist. And there are pros to that. We need to be able to care for as many people as we can, and we need to not promote a learning deficit where there's an entire generation of generalists who never learned about a medication. But at the same time, the primary care provider is dealing with a laundry list of issues, and it requires a whole appointment to talk about this new class of medications, the side
Well, it
effects.
has to be done also in a very special way, right? Like
Yep.
titrate it up. You can't just like
Exactly.
start with a dose and so you have to put aside a period of time for the patient as well to say, you're going to be on this drug for X amount of months and we're going to be working up, to higher and higher doses and then seeing what happens and then making decisions then, right? So all of that requires a little bit of experience, it seems, and knowledge about the drug.
Definitely knowledge about the drug, experience and time and infrastructure in your health system to devote that time. And we do that very well for cardiology, for blood pressure management or insulin management. We found ways to use not just MDs and physician's assistants, but other parts of the care team to help with that dose escalation protocol. And so there are ways to be creative from a time management standpoint, but also from a fidelity standpoint for patients. They don't need to always be coming in. We can harness telehealth in a safe and effective way for some of these appointments, but it really needs buy-in from everybody, including the patients, to come in regularly for those checkups.
Okay. Wonder if you can also address things that we're beginning to see from patients who are seeing the weight loss, they're kind of happy where they are, but maybe they haven't reached the maximum, dose that is in the label for the drug. And we're also hearing about trends of microdosing, people who are wanting to lose a little bit of weight, and then they're happy, with where they are. Are you seeing that a lot with patients that come to you? And how do you talk to patients who are who are seeking more flexible and different regimens of these medications, and how strict should doctors be about sticking to the package insert?
I'm a firm believer in patient-centered care, so I'd love to have the conversation with someone who doesn't necessarily want to take it weekly. These drugs have a very long half-life, so there are some patients who don't need to take it every week. And we all know hunger. That's something we experience, whereas we don't experience our cholesterol going up. So you can trust your patients to go based off of their hunger cues within a reasonable time frame. You don't want to prolong the dosing so much that they're going to have a lot of side effects when they resume. The first question about dose, we know that there are hyperresponders, especially with the dual agonist tirzepatide. And we have a lot of, we know these hyperresponders tend to be women under the age of 50. And so in my practice, I have a lot of younger women, mid-30s, early 40s, who are losing a lot of weight on 5 milligrams alone. And so that's another reason to be checking in, because you don't want to send a hyperresponder off for 6 months and check back in with them and have created some health consequences from losing too much weight too quickly.
Right, and because we've heard also concerns about muscle issues, right, with these medications. And so how are you counseling patients about that? Does it come hand in hand with saying you're going to be starting this medication, and also you need to be, making sure that you continue with like weight training, or, is there additional advice that you're giving to these patients?
With any form of weight loss, you lose fat and muscle. It's not unique to the GLP medications. We know this very clearly from the bariatric surgery patient population, as well as through lifestyle change. So it's important to know that this is not unique to medications for weight loss. The average American, regardless of weight, is not exercising enough, and we know that exercise minutes decrease quite rapidly with each decade of life after 30. And so a lot of that work in the early stages, after someone is on the medication and not having a lot of side effects, is trying to really engage in both anaerobic exercise, so strength training, and aerobic exercise. We know also from the bariatric population that if people are doing strength training while they're losing weight, they have a good chance of retaining their muscle mass. So we talk about all of this before starting the medication. Here's our 1 month, 2 month, 6 month, 12 month. Here's how we're going to think about this in the long term. And we go based on how the patient is doing, their motivation to put in those puzzle pieces one by one. But the goal does need to be that we're getting strength training in as early as we can in that process.
Okay. Nora, I want to come back to this idea of these medications and their effect on the reward centers of the brain. Are there any concerns if we continue to manipulate and tap into that system, about what it will do. As you said, it's a very basic, evolutionarily driven system that helps us to survive, right? It finds high-calorie foods, for example, because we need calories to survive, to feed our cells. Are there any concerns about what sort of manipulating and being more intentional, about changing this system will do for other reward-related activities and functions in the body?
Yeah, no, of course, we have to. This is an important question that has actually made it very difficult to bring medications against obesity that are effective into the clinic, because there have been medications that have come into the market that were interfering with that reward system, but they promoted suicidality. So as a result of that, they had to be removed from the market. That is not the case with the GLPs. And at the beginning, and not very long ago, there was concern that these medications may be associated with higher suicidal behaviors. And we and others have gone into the electronic health records to actually evaluate, is that the case? And actually, FDA did the same thing. And there's absolutely no evidence that these medications are increasing suicidal thinking, ideation, or behaviors on patients that are receiving it. So because it relates to that issue, we need reward also for our sense of well-being. And so if you are interfering with that sensation of pleasure, are you putting people at risk of, say, depression? And also, as you say, loss of interest in other activities. There is no evidence, and I've been asking this question with respect to what does it do to sexual drive? Are people then less engaged? And the answer as of now, apparently, it does not interfere with sexual motivation. But clinicians that are prescribing these drugs may be in a better position to determine, but this is where right now where the consensus is. And similarly, people engage. So the reward that we get with other activities, like social interactions, like the interaction, the personal intimacy with someone, that reward that is very, very important, that is not interfere. There's no evidence that it interferes. It appears that it relates more to compulsiveness. So in situations, for example, where there is compulsive gambling, and now researchers are starting to look at it, or there's compulsive sexual behaviors, that's where you may be interfering with the sensitized drive, the increased saliency of that behavior. And it does, it brings, again, into notion of if we can separate the responses of while protecting normal physiological reward mechanisms, while protecting us from those that lose control and lead us to escalate on behaviors that are very harmful, then this could be very powerful medications when used appropriately, of course. But so there's no evidence, to my knowledge, that they are interfering with physiological rewards or social rewards.
Are there studies, though, because it seems like this is something that you would want to study long-term, right, and see what, because potentially some people may be on them, off them for a little while, back on them, particularly for weight management, and that could really sort of reset certain thresholds in the brain and the way that the brain perceives and processes reward, right?
Absolutely, and you also generate an expectation, and that's something that the clinicians have to be very, very aware of, because if a person doesn't fit that expectation, then they may feel depressed about it. And the truth being is that, yes, we have 20 years that they've been using for diabetes and 13 for obesity, but the second generation GLPs, which are the semaglutide and the tirzepatide, those are more recent, and I think as you deal with them for obesity. So we need to look long-term. They look quite safe, but what's going to happen 20 years? And also diversity of populations, right? I'm very interested, and I would want to know, what about pediatrics? What about, I mean, what are the consequences? Or in principles, it seems to be safe if you are pregnant, correct me if I'm wrong, and you are giving them, I mean, there's no evidence that there's anything harmful, but what about the newborn? And all of those, we don't have sufficient information if there are new medications.
Sorry, you're not supposed to take them when you're pregnant because there's increased risk of placental disruption and fetal loss.
Okay, here you have, yes. Well, I'm glad you're telling me because the pharmaceutical has not told me that. So,
and so we're also getting very close now. These medications are currently injected weekly, so we're getting very close to having oral versions of these, and that really could be another game changer. You know, we're talking about how game-changing these medications already are, but to have a pill that people would take even daily is going to be huge. I think it's going to address cost, which will then affect access. And I wanted to ask you, Martha, do you think that will have an impact too on heart disease? And people are already taking statins daily, right? We've got like millions of people taking these pills daily. Yeah. If this becomes an oral medication, do you think it will expand the heart patient population that's going to be able to take advantage of them?
I think it will expand it. We do know, of course, there's some limitations. You add in more meds, patients take less meds. Like, I mean, it's right now, of course, people are very motivated because of the thing that is physical that happens to them. It's almost like taking an injection suddenly has become so easy. And you think about things like PCSK9 inhibitors, I'm like, it's the same needle. Like, why did we not have rush of people?
And these are cholesterol-lowering
agents,
right.
But nobody rushed to us asking for them the way that these drugs have been requested by patients. I do think, though, by having oral, the cost issue will become less, and that means more people will have access to them. But understanding, again, whether patients will take them, like the sort of pill burden that still limits what people do. The good news also is it's not just these medications. I mean, in the last few days, the American Diabetes Association meeting has been going on, and I'm not even fully caught up on all the drugs that were discussed there. Phase 1 trials, Phase 2 trials, and Phase 3 trials were all released there. And there's going to be new medications that work better, that are going to be competitive. Maybe they're going to have less side effects. So all of this we're so interested in, but as already was said, we need duration of time to know long-term effects of what we're giving to patients. And so I think it's the most exciting time in the sense that we have never been able to address this risk factor, and we can do it in a really meaningful way. When people do have severe obesity, being able to take that and change it is nothing like even with the best, most compliant patient that was able to change their diet dramatically or start adding in exercise. We could never get this kind of weight loss before. And so I do think that part of what will make people more compliant with this drug is how they feel on it, meaning are the side effects insignificant to their quality of life, and does it change them physically, which for obesity really matters.
Right. I'm glad you mentioned that because, Diana, I want to ask you, this is a medication that's really helped people to drop double-digit weight loss, right? And for so long, we've heard that one of the walls that people hit when they do diet and exercise is they're only losing that small percentage. They don't really see a change. They don't feel very different. And so it becomes a question of motivation and, you know, what is it doing for me, right? For the first time, we have something that people can actually, you know, feel like, oh, that's what it's like not to feel winded, you know, when I go up the stairs in my home to the second floor. How important is that aspect of this in then motivating people to keep up with the diet and exercise, the behavioral part, which goes hand in hand with taking these medications?
I think there's a lot of nuance to that question, and part of it is not that people lose motivation, it's that life happens, and there are people who have predilections to different stress response mechanisms and to obesity, and if you don't have that, it's hard to necessarily understand how that is what you seek. You seek food for comfort, or you've just grew up in a house where you didn't have food, so you don't waste food now. These things we can't necessarily attribute to just a choice, and the medications help quiet that noise in your brain. It helps you be able to make those choices that you've wanted to make or you've made successfully in the past. And so I don't think it's as simple as I didn't lose very much weight, so none of this was worth it, I'm going to stop my lifestyle change work. I think it's more, this is very psychologically challenging to keep up with all of these efforts I have to take to lose a little bit of weight, but I still have all of these cardiometabolic diseases. Whereas with the medications, that mental burden is not there as much. You physically feel more full, and you also are starting to see improvements in your blood pressure, alcohol use, fatty liver disease, so on and so forth. So I think it's a bigger picture, and the medications help people successfully execute on the planning that they've wanted to do and have done successfully in the past.
How would you characterize the bulk of the patients who are coming to see you and asking about these medications? You know, are they people who have tried other strategies and really struggled with them and are still motivated to lose weight? They understand, you know, what it does metabolically and how harmful it is to their health overall to remain overweight or obese. Who's coming to you asking about these medications?
Now, I run an academic medical weight management program at a tertiary care center. So these are patients mostly coming from our primary care colleagues or from our subspecialists. So these are people who need to lose weight to get listed for a lung transplant, or someone who has fatty liver disease and hepatitis B, and you know, all of these issues, and they really need to lose weight. That's who I see. Who wants to see me and who's getting referred to me is everybody. Yes. And I hate saying what I do at cocktail parties because everyone wants my thoughts and opinions and the micro dosing, and should I take it on Friday so I drink less on Saturday, or, you know, the want is most people. But who I'm seeing at a tertiary care center with limited resources and access issue are patients who have more complex medical needs because of their adiposity and excess body weight.
Right. But do you think that in terms of the patient, and I wanted to ask each of you this, and maybe we'll start with you, Martha, in the heart disease community, you know, are we going to see a change in the type of patients who are going to be on these medications now? You know, we're right now at those who are probably at the higher risk side, right, of the spectrum. Are we going to see this shift toward more kind of frontline preventive care, do you think?
Well, I do think, especially for those with heart disease, this is becoming part of the treatment package. And so just like we're addressing the other risk factors, we're going to address obesity at the same time, or excess weight when you have other organ involvement. So I do think that this is now part and parcel of our management. I will say, though, that there is still people in our community, and I'm just speaking for cardiologists, who, and you'll see it on social media, sometimes you'll see people post, I just think that people need to eat less or move more, that these drugs are not the answer. You'll see that often, and I'm very shocked because we know that patients have struggled. Like to your one question that you were saying, I mean, almost everyone who has gained excess weight wants to lose excess weight. Nobody wants that excess weight. It's just, like you said, life got in the way. Things happen and make people gain weight. Many of us remember COVID. COVID happened to all of us. I gained weight. You know, like, so it's hard to lose weight. I realized after that for the first time in my life that I had to lose weight and how hard it was. I can't even imagine for somebody with, you know, with severe obesity, how hard. And they've tried everything. They've tried every diet. They've spent more money on other, you know, over-the-counter supposed cures, solutions, shakes, you name it. And so I think it's great that we have these medications, and we have a lot to do with educating the entire medical community so that patients who need it will get it, because we can shift the curve. There's a really nice paper that was written recently showing that only a fraction of patients are really getting these medications who meet the criteria. And so we're not shifting our US BMI distribution, but if everyone who needed it got it, we would shift the BMI curve for the country, which means we would lower risk of cardiovascular disease. So that's the potential. We've got to work out the logistics of affordability, chronicity of treatment, et cetera.
Diana, same question for you. Do you foresee if we blue sky a bit, do you foresee, we know some of the risk factors for obesity, some of them are genetic, a lot of them are environmental and behavioral, but they are pretty powerful. So do you foresee a potential for these medications in other forms? We're talking about microdosing or lower doses or different versions of them that could be used to prevent obesity. The same way we talk about prediabetes and preventing people from getting diabetes, can we intervene earlier in this way with medications to prevent obesity before we get to all of those metabolic consequences?
I think there's a world in which if we did better screening around weight gain that happens, the average woman in America gains 20 pounds in her 4th decade in life. And so if we're screening better for these times of risk and understanding what segments of society and population have these risk factors, immigrating to the US is a huge trigger. And so if we can find those trigger points and try and harness lifestyle change before it hits, then that would be ideal. But if we can't, I think lower doses of these medications could be an option, but we have to weigh the risks and the benefits of this. And if we're inducing risks in patients who have normal weight, they're overly suppressing appetite, they're not living a nutritious, healthful life, that's tipping the wrong direction. So perhaps it's more understanding pre-disease states like prediabetes, prehypertension, and getting that patient population who's gained weight and those diseases have come on board to have lower doses of the medications. But just as a general thing as prevention, I think there's too many risks right now for that to be a strong recommendation.
Nora, I know that the data is still further behind on psychiatric conditions and addictions, but do you also, if you're blue skying it a bit, do you also foresee a future where some of these medications could be used as a way to protect people from shifting over into those conditions?
I'm glad you asked that question because I really never had thought about it. And it forced me into saying, well, which one is the obvious one, which is a very important one. We're just emerging and still struggling with the overdose crisis that was actually triggered by overprescription of opioid medications. So there are many, many patients in America, 50 million people with America with chronic pain conditions, 25 million with severe pain, and we don't have effective medications for pain. They're very, very limited. Not everybody responds, so we rely on opioids. So if we were to give opioids, and for example, the possibility, could we use a combination and interfere the changes that happen that leads you to the conditioning, to the desire for more drug, to the escalation? Could this be a possibility for preventing people that need their opioid medications for pain to become addicted to them? That's one example. But it also, you launch into my brain a series of other thoughts that have I also been struggling very much. When someone initiates in the opioid world, first of all, we don't have many medications for addictions. We have medications for opioids, for nicotine, and for alcohol. That's it. Nothing for cocaine, methamphetamine, nothing for cannabis or any other drugs. So, but for the drugs that we do have, say, for example, in opioids, we are using medications that are quite effective, methadone and buprenorphine. But methadone and buprenorphine actually, they act on the same opioid receptor as heroin or fentanyl. So this has generated a lot of stigma for these drugs. But there are many reasons why they also act differently. But say, for example, that you have a young person that is taking opioids. You don't want to give them, for example, you don't want to start them yet on buprenorphine or methadone, but yet you want to protect them from escalating. This could be a possibility. So if you can show that they decrease the reinforcing regarding the saliency value of the drug, then you can interfere with that escalation pattern. That is what happens in the trajectory. And in that respect, so if it works, one could conceive it as an early intervention when addiction is starting to emerge, but it hasn't reached the levels where you would be concerned about. So I do believe that it has the potential, certainly with the issue of the pain, and that's a low-hanging fruit to study. But this other possibility open up the door if we do show that they are effective medications against addiction.
Interesting. Okay. Well, I do want to open up and give the audience a chance to ask questions, and we've got a few. So I know we have some mics in the room. Let's start right here in the middle.
Thank you so much for all of this information. It's on. I have a question. You addressed this a little bit. In looking at the wellness arena, would you think about using, and if cost were not an impediment, would you think about using these drugs prophylactically as a prevention for future heart disease? So given that the patient isn't a patient yet, but you're really looking at wellness and health span and that whole arena, is there a use for these drugs?
So currently, right now, I mean, I'm pretty evidence-based, so I follow what our data shows, and the type of persons are the people that have been in the trial. So those were people with cardiovascular disease who had excess weight defined as a BMI above 27. So not necessarily obesity, but definitely in the overweight category. That was who was in the trial, and where we have the very strong data saying it reduced cardiovascular outcomes by 20%. So that's who I use them in now. I think we're always going to need the data behind how we use them. If you think from a preventative standpoint, giving them to people who don't fit the criteria or don't have obesity, we don't know that that would be of benefit. We think, you know, the strong relationship is between not just, there's probably cardiovascular effects, and we know that too, but there's also profound impact on cardiovascular risk factors as well. And so it's a little bit of both.
Okay. Let's go to this side over here.
Thank you so much for such a superb session. To the expertise for the speakers, and Alice, as usual, you do a terrific job. We should start calling you Dr. Alice for the profound medical questions you ask. Since the topic of this, subject of the topic was what can it not do, I would like to ask, have you been, I'm not up to date with the medical literature, but has it been tried in the prison population to address the obsessive aggression, maybe especially in the repeat offenders?
To my knowledge, no. And it's actually, you know, it's very hard to do research in individuals that are in prison because there are protective laws to try to actually, so that there's no coercions to participate in a study. So I am not aware of any studies, so I suspect they haven't been. And again, I do not know. I think that this is something, for example, where studies in laboratory animals may be able to actually shed some light. So if you can breed certain animals, rodents are bred for these, that have excessive physical aggression, and try to see if these medications could be beneficial. I do not know. I think that there are models where the aggression is more compulsive and it has a rewarding effect, and where interventions that interfere with that rewarding mechanism, which is very much centered through dopaminergic pathways, actually can, if you block them, you can block that type of aggression. But those are laboratory experiments, and human violence is much more complex than that. But one could start there, and I'll get back and I'll start looking at whether anyone has even looked at it. So it's an interesting question.
Okay, over here.
Well, one thing you didn't mention that has increased is my bank account, because I now share dinner with my wife. So I don't have to pay for 2 dinners at expensive restaurants in town. I want to know if something's common. I've been on semaglutide for 3 years now. And at that time, I lost all urges for carbs and sweets and everything and wine. But recently, over the last few months, I've had urges for ice cream, York peppermint patties that I didn't have before. Is that something common that after you're on for a long time, the semaglutide or any of the GLP-1s, that you develop that?
That is why a lot of the medications historically didn't have the long-term effects, because those psychological effects of the medication do seem to wear off eventually over time. And the brain is very powerful, and we eat for reasons that have nothing to do with hunger. And so when some of the medication starts to feel less powerful in the brain, and some of those cues and habits that return they come back more, and that is a challenge that we're seeing more now that this has been out for 3 to 5 years. I don't know from your space.
Yeah, I wonder, is there like physiological evidence about tolerance?
It's not a tolerance in the way that we think of tolerance for other medications. People's A1Cs are not going up in the diabetes population. Their cardiovascular disease risk isn't going up, even though there was weight regain. It's really those central effects that are less powerful and potent, which we're trying to understand.
Is it helpful to go, or is there any evidence to show going from semaglutide to, say, Zepbound or another GLP-1 would be helpful?
It'll be a similar situation where the medication is a different type of drug. There's 2 agonists involved, so you will have some more of the dampening of that central effect. But over time, we suspect maybe that timeline will be longer with something like tirzepatide, but that will return to a certain extent. But a small amount of weight regain is okay. You still will have those metabolic, cardiac, liver, kidney improvements in your health, but that feeling for the patient, what I've heard from others is that it is really disturbing, and it is very concerning and can be triggering for sort of relapses around food that people have had in the past.
And how frequent is it? And if they have those desires, do they fall into the compulsive patterns? Have you seen that?
We haven't seen people who have binge eating disorder or true compulsive eating fall back into that level of eating. It's more just, oh, I'm having these cravings. I use the tools in the toolkit to not indulge as much, or I'll have 1 York peppermint patty a week, or it's more of a treat, whereas I was never craving it before. So it's definitely not to the same extent. But so many patients, as you said so eloquently, they've been dealing with excess body weight for so long, that psychological trauma of, oh my gosh, this is what happened when I lost 40 pounds 10 years ago. It's going to all come back again. So a lot of it is counseling around that. There's more guardrails now. The weight may go up a little bit, but it's not going to go back to what it was before or even worse.
But Nora, physiologically, is there a basis for, this type of, if it's not tolerance, just this fact that, because we hear so much about initially when people are on these medications, that food noise is significantly, dramatically decreased. But as it comes back, is there a physiological explanation for that in terms of how it's working in the reward center in the brain?
From that description, and I actually was not aware of this, but these are condition mechanisms, and the conditioning is what you automatically, when you see something, it creates that desire. Now, what these medications seem to be able to do is to control it. So why is it emerging? And that's why my question then, is it emergence in an isolated, and then you take the ice cream and that's it, then no negative consequences. So, but if you do, that triggers the binging, then yes. And if it doesn't do that, I think it's the issue working with the patient and cognitively making them or him or her aware that as long as it's an isolated episode, that this could be something that they could look forward for, one treat once in a while. So I think that, but it is a condition. Condition responses are very powerful, and that has led to the question that when people are addicted, they are addicted for life, and that they cannot ever stop taking the drug, and they can be in dangerous situations We know that no, it's not completely true, but conditioning is a very powerful driver of our behaviors, and in certain circumstances, you may have never thought about something that was a negative behavioral trigger, and it triggers them. It can be an emotional, a stressful situation, or being exposed to it. So, and it can happen to any one of us.
Okay. One more question. Wow. Let's have one in the middle right here.
I have a question for Nora. So are you aware if, or do you anticipate GLP can be applied to other substance use disorder in addition to alcohol use disorder, which we now have a lot of evidence? Just wondering if those reward systems are shared or unique between different type of substance.
Absolutely. No, I basically, based on what the data is been showing, it actually does appear to show promise for tobacco cessation. It also appears to have benefit for cannabis, for opioids, and for cocaine and methamphetamine. So we are exploring the various types of drugs. And so it's not just that alcohol has energetics and can be used as a source of fuel for the brain. It is that reward system where you actually have glucagon receptors in the dopamine system that drives drug taking. It is modulated in part by these GLP receptors. They regulate how our dopamine cells fire. So this is one of the mechanisms by which actually you can foresee why these medications could have potential benefits for decreasing the drive, the intensity, the escalation, the motivation to take the drugs. So I do hope, again, because we do need medications for addiction and many more alternatives than what we have, that the randomized clinical trials will show effectiveness.
All right. I think that's a great note to end on. Thank you very much, Martha, Diana, and Nora. Really appreciate it. And thank you for your questions.